So we are live. You can start.
Yeah, thank you. A very good evening and warm welcome to all in the audience for today's program, which is Ruma DG Conclave. We are having with us eminent personality, consultant rheumatologist, Dr. Pradeep R. Kumar. And I really thankful to sir for taking out your precious time for today's session, sir. Welcome to the session as a speaker. Today's topic is very interesting, all in the audience. Topic name is Approach and Patterns of Arthritis. Sir, Dr. Pradeep Kumar, he's a consultant rheumatologist. He has done his MBPS, MRCP, MD, FRCP, CCT, senior consultant. Sir is currently practicing at Hospital Bangalore, Muzumdar Shaw Medical Center, Boma Sandra. Little more brief about sir's introduction. I would like to tell you all in the audience that Dr. Kumar has a rich experience in the field of rheumatology. He is the author of more than 15 publications in several known journals and has a very rich work experience. Moreover, if I talk about professional memberships and the certificates, sir has a Scottish Society for Rheumatology in 2002, then British Society for Rheumatology in 2001, Royal College of Physicians at Edinburgh in 2009, Scottish Academic Rheumatologist SCAR in 2008, Scottish and Irish Registry on Ankylosing Spondylitis SIRS in 2008, and Indian Rheumatology Association sir is a member of from 2015. So with this, I welcome everyone in the audience. Thanks for joining today's program and a very nice session by Dr. Pradeep R. Kumar. Thank you very much, sir. And over to you, sir. Now you can proceed with your session. Over to you.
Okay. Good evening, everybody. And thanks to Zydus for sponsoring me and also for giving me this wonderful introduction to Vishal. Today, I've actually split the talk into two bits, an approach to polyarthritis and also a little bit on rheumatoid arthritis as well, because that is a prototypical polyarthritis. So if you learn rheumatoid arthritis, you can learn more about the medications used in most of the polyarthritis, the disease-modifying agent. So when we think of polyarthritis, so the way we approach subconsciously as rheumatologists when a patient with polyarthritis come to us, these are the questions which does go through. I've objectified what we think of it. First question we ask is whether it's inflammatory or non-inflammatory arthritis. And then the chronicity, whether it's acute or chronic, whether it's young males or females or postmenopausal female, the demographics of the patients, and the pattern of distribution of the arthritis, and the pattern of arthritis itself, whether it's intermittent or not, and based on other extra-articular manifestations. So these are all the questions which go through our mind. I'll go through it one by one. Inflammatory versus non-inflammatory arthritis. This is very basic. Clinically, we know that if they have Calor, Rupert, Dollar tumor, and the functional loss, that they do have inflammation. But more than that, we rheumatologists are obsessed about asking the history of morning stiffness, which again, most of you would know. It's very basic, but it is extremely important. This early morning stiffness is like doing a blood test for CRP for finding out the extent of inflammation. And if the stiffness lasts for more than half an hour at least, then it is suggestive of significant inflammation. There are also a few other small nitty-gritties that if the pain gets worse after rest, contrary to degenerative problems where the pain gets worse after the prolonged activity. So that also suggests towards inflammation. And if they have acute phase response like the elevated ESR CRP, that will be good. But usually we don't find that useful. And nothing like asking for the history of early morning stiffness. So please, this one point, even if it is simple, has to be taken away as a take-home point that it's important to ask in every patient who comes with polyarthritis, the early morning stiffness and its duration. Next, the chronicity. How long has a patient had polyarthritis? Whether in the short period within 6 weeks, then we think of infection or post-infective, and other normal chronic inflammatory arthritis can also present acutely. If the arthritis onset has been for a long period of time, more than 6 weeks, then it could be inflammatory or it could be non-inflammatory, which is degenerative or even psychological, such as fibromyalgia. So with regards to acute polyarthritis, the lots of infection can cause it. In Western world, it's usually parvovirus, which is the commonest form of viral arthritis. But in India, as you all know, that it is chikungunya arthritis. This chikungunya arthritis, I want you to know a bit about it because it's so common now. Since the coronavirus lockdown and everything has happened, people are all sitting at home, and these mosquitoes have really caused more than a pandemic, I think, epidemic of chikungunya arthritis. Classically, what we have to know is this post-viral arthritis affects the lower limbs than the upper limbs, but it can affect all over. It's usually symmetrical, and they have significant early morning stiffness with acute onset, as mentioned. And they also have some overlapping features of other mosquito-borne diseases. For example, filariasis will have some leg edema. So same thing, post-chikungunya arthritis, they also get a little bit of leg edema. That's very cardinal feature of this post-chikungunya arthritis. They can have low platelets like dengue. They can have skin rashes, sometimes even diffuse skin rashes like dengue, and like malaria, chills and rigors. So they can all have overlapping symptoms to other mosquito-borne diseases. And that's the way we pick up. There are no good tests for chikungunya virus. Unfortunately, the IgM for chikungunya, the yield is really poor. Only 10% is positive. The PCR for chikungunya, the yield is better, but unfortunately, it is not done everywhere. So in Bangalore, we send it to NIMHANS. But again, still the yield is only 30%. So in general, the blood test for chikungunya is not that useful at all. And sometimes we do see the patients coming and saying that I've done the test for chikungunya and it's negative. But it could still be chikungunya if the pattern is clear cut. Another thing, this chikungunya is so rewarding. It's so common now. So lots of people don't know how to treat it. It's very simple. So I see so many physicians and orthopedic surgeons giving non-steroidals, oral steroids, and all those things. They all do work, but there's a huge chance of recurrence of the joint pains, because when you stop abruptly, it does come back. So what we find it very useful is giving a long-acting triamcinolone injection or even a depomedrol. So long-acting intramuscular injection. It's not even IV. Even intravenous injection, even if the dose is high, do not work as well as the intramuscular injection. So giving one dose of 120 milligrams of triamcinolone cures this post-viral arthritis in almost every one of them. And if there are some people who have some remnant problems, then you can give another dose of it, and that almost certainly 100% of the time will cure it. So that's chikungunya. And there are other kinds of acute polyarthritis, which is non-infective, which is also can be post-infective, like reactive arthritis, but this is like much longer. So the infection can be long back, or sometimes patient cannot even recollect the infection, but they can present as reactive arthritis. The difference between post-viral arthritis and reactive arthritis is, in reactive arthritis, there'll be huge joint swelling. So the knee is completely swollen, the ankle is completely swollen, which is very unheard of with post-viral chikungunya arthritis. So with reactive arthritis, the difference is you need very high dose of steroids, and most of the time they respond only to intravenous methylprednisolone of up to 500 milligrams, 2 to 3 days. And then they have a huge chance of recurrence. And for that, we need to maintain them a small dose of steroids and even start sulfasalazine for some time till they feel 100% normal. And only then we try to taper it off. So the reactive arthritis, the one subset of reactive arthritis, which you all know, is the Reiter syndrome, where there's a triad of conjunctivitis, urethritis, and arthritis with keratoderma blennergicum. So this is not that common. Post-chlamydial infection, this is seen, this triad, but normally post-gastrointestinal, like post-salmonella, shigella infection, you just see reactive arthritis with swollen knee. The knee sometimes will be so swollen and so tender, it will cause rapid loss of quadriceps muscles. You know, the surrounding muscles get wasted so much because of the extensive inflammation. And in fact, if you try to aspirate this knee, most of the time it will be looking very purulent. This is again a common mistake I've seen with a few of the orthopedic surgeons. They aspirate it and they see it's like, looks like pus, and they immediately drain it or they open it up and stuff. So there's a lot of polymorphs, neutrophils will be there inside the fluid. So it can be purulent. In fact, they also have some fever too, and they'll be extremely tender and red hot. So it'll look like infection, but usually it's not. It's reactive arthritis, which is extremely common, especially if they have more than one joint, like two joints, so the knee and the ankle is swollen, then you think more towards reactive arthritis than just an acute infection. If it is chronic, then the classical, as I said, the prototypical inflammatory arthritis is rheumatoid arthritis. And there are so many other, the list which I mentioned can all cause chronic inflammatory polyarthritis. The non-inflammatory polyarthritis, as you know, is osteoarthritis. I will just briefly touch on that later. And then based on the demographics, again, we do diagnose it. So if a young male comes with a back stiffness, with significant early morning stiffness, we think of ankylosing spondylitis. So you don't have to do HLA-B27 or MRI scan to diagnose it. And similarly, if again a young male after a drink or a heavy non-veg food develops a first MTP joint pain, then you think of gout. You don't need anything to say it's gout. And again, if a premenopausal woman comes with arthritis, don't diagnose osteoarthritis. A premenopausal woman rarely get osteoarthritis. They have to be postmenopausal. So the age factor also will give us the diagnosis, sometimes even straight away. The distribution of the arthritis, symmetry. Symmetry is a very interesting concept. So if the arthritis is very symmetrical, then it is most likely to be rheumatoid arthritis. SLE, and even as I already said, chikungunya type arthritis can also be symmetrical. If this arthritis is asymmetrical, then it could be any seronegative spondyloarthritis or any other kind of arthritis. The symmetry, you have to remember, we don't look at the symmetry like it has to be the exact joint. For example, it doesn't have to be the MCP of the index finger on the left to the MCP of the index finger on the right. So it could be the MCP of the index finger to the MCP of the little finger, and we still call it symmetry. So, and this symmetry is also believed to be neurological. For example, if a patient with polio or stroke develops rheumatoid arthritis, they do not get symmetrical arthritis. On the side of the stroke or the polio, they actually do not get arthritis at all. This makes us think that the symmetry is actually neurological, and this is an interesting phenomenon. So the pattern of involvement will also give us a diagnosis. So these are all the joints affected in rheumatoid arthritis. Classically, we say that's the index finger and the middle finger, MCP joints, and PIP joint and the wrist. So if these joints are affected, and if it's swollen and it looks like a soft, boggy synovial swelling there, then you don't need any test to confirm whether it's rheumatoid arthritis or not. That has to be rheumatoid arthritis. And if it is chronic, obviously. If someone comes very late stages with all these deformities, you really, again, don't need anything. You don't need any intelligence to say this is rheumatoid arthritis or not. So this swan neck deformity, MCP subluxation, swan neck, the Bottom's deformity. So all these things, if they have it, then it's classically rheumatoid. In psoriatic arthritis, the joints affected are like usually large joints. There's different types of psoriatic arthritis. And if it affects the hands, it's usually the DIP joint. And then if it affects the spine, the sacral leg joints are affected. And what I've shown in that picture is like the dactylitis. So if someone has toe swelling, and that's important to remember, whatever kind of polyarthritis they come up with, but if they have toe swelling with the entire soft tissue of the toes swollen, or even the fingers, then that directly tells us only a few conditions. So it could be psoriatic arthritis, reactive arthritis, sarcoidosis, or tuberculosis. And sarcoid and tuberculosis being relatively rare, so we think of psoriatic and reactive arthritis. So picking up this dactylitis is very useful clue. Enthesitis is another feature of spondyloarthritis. So someone has this sort of Achilles tendonitis. So enthesitis is basically any insertion of the tendon, ligaments, or fascia to the bone. In that insertion region, if there's inflammation, then it's called enthesitis. And we believe this enthesitis is a starting point of all kinds of spondyloarthritis. So if they have enthesitis, again, it directly gives us a diagnosis of spondyloarthritis. In osteoarthritis, again, this is all known to everybody. So the joints, the hands, there are different types of osteoarthritis. So the postmenopausal women most commonly get it in the hands, and that is the postmenopausal osteoarthritis. They later on end up having this Heberden's nodes and Bouchard's nodes. So they have all these bony prominences in the fingers. then this is classically osteoarthritis. If someone presents with just the knee pain, crepitus and stuff, then you know it's osteoarthritis. So based on the pattern, the distribution, we obviously can diagnose what kind of polyarthritis. The pattern itself, the intermittent arthritis. Here I want to stress about the gout and palindromic rheumatoid arthritis. So the gout type arthritis, they'll have an acute onset, but the attack initially, the first 1 or 2 attack, lasts for 7 to 8 days, 7 days. So it doesn't settle within 2 days, and usually it doesn't take much longer too. So maximum 10 days. The palindromic rheumatoid arthritis, the attack settles within 48 to 72 hours. So patient will get an acute attack, and if the pain goes off in 48 to 72 hours, and then they will have a symptom-free period, and then after some time, if they again get another attack, which also lasts for 48 to 72 hours, then we call it palindromic rheumatoid arthritis. So that duration is very important. So based on that itself, we can diagnose. If it's a classical first MTP joint arthritis, we know it's gout. But if it is any other joint, like a knee or ankle, which can also sometimes be gout, and if the attack is lasting for more than 3-4 days, we don't think of palindromic rheumatoid arthritis. Again, you know, the migratory type arthritis, today it's in the knee, later it's in the ankle, then it's in the hands, then you think of rheumatic fever. So basically, based on the pattern of arthritis, you can also diagnose what kind of polyarthritis it is. For rheumatoid arthritis, osteoarthritis, and spondyloarthritis, usually additive, which means as time goes on, they will have more and more joints being affected. And finally, the extra-articular manifestations. This is also very simple. It's a pattern recognition again. So if someone has polyarthritis and they have a nodules like this, you think of rheumatoid nodules and you think it's rheumatoid arthritis. So that's the same here. So you don't again need a lot of IQ to say that this is rheumatoid arthritis if you see classical rheumatoid nodules. So this, again, I have mentioned earlier that this dactylitis. So if you have a dactylitis, then you actually look for psoriatic patches. So when you have plaque psoriasis, then this is psoriatic arthritis. You don't need any test to confirm this. These are again the sites where you have to actively look for psoriatic patches. Lots of time we rheumatologists have been caught for not looking for this. It has been diagnosed as rheumatoid arthritis by even some other rheumatologists, I have to say. And then if you probe and ask further, all that they'll have is a very small patch near the umbilicus, or a small, they feel like excess dandruff in the scalp or behind the ears. And if you get that, then the diagnosis is psoriatic arthritis. Nail changes, say they have this classical nail changes with onycholysis, in early stages pitting, and if they have polyarthritis, then this has to be psoriatic arthritis, right? These are all the other pattern recognition from the extra-articular manifestations. If they have tophi, so this tophi is like, it's not rheumatoid nodule, it's like you do see this yellow chalky appearance. And if you see this tophi and they have polyarthritis, you think of chronic tophaceous gout causing joint pains. This is if they have butterfly rash, and if they have polyarthritis. If you have classical photosensitive rash, if they have discoid lupus on the scalp, what I've shown there. If they have Raynaud's phenomenon, then you think of connective tissue diseases causing this polyarthritis. So these are all the extra-articular manifestations you need to remember. When you're asking the history of the patient of the extra-articular manifestation, what I would always have a routine of saying 2 questions from the eyes, which is history of dry eyes or red eyes, 2 questions from the mouth, which is history of recurrent mouth ulcers or dry mouth, 2 questions from the skin, which is history of any rashes and photosensitive rash, and 2 miscellaneous questions, which is basically Raynaud's and alopecia. And in the women of childbearing age group, you ask for history of recurrent abortions. So if you ask these 9 questions as a routine in every patient who presents with polyarthritis, then you're not going to miss almost any rheumatological problems. This is another classical adult onset disease where there's a triad of fever and joint pains and this evanescent rash is what we call, which means like when you do a ward round, you go and see that there'll be this maculopapular rash in the chest wall, and the next day you go and see the patient, the similar rashes will be there in the abdominal wall, and later on it'll be in the arm. So it keeps moving. Okay, this is what we call an evanescent rashes. And if you see this kind of rashes with the high fever and joint pains, then the diagnosis is adult onset disease, and you confirm this by doing serum ferritin levels, which will usually be very high. This is very classical erythema nodosum, and if they also have this hilar bilateral hilar lymphadenopathy, then if they have arthritis, then you think of sarcoidosis, acute sarcoidosis. Acute sarcoidosis, there's again a pattern recognition with regards to the joint. It almost always affects the ankles, plus or minus knees. So if someone presents with bilateral ankle swelling with a skin rash in the shins, then you think of acute sarcoidosis. You don't need any tests to confirm that. This is classical pyoderma gangrenosum. So this also, once you pick this up in early stages, then you have certain set diagnoses you can make. So it's either very severe rheumatoid arthritis or inflammatory bowel disease, Crohn's disease and ulcerative colitis, and rarely in sarcoidosis and redness. But commonly it is Crohn's, ulcerative colitis, and severe rheumatoid arthritis which causes this pyoderma gangrenosum. There are other hematological conditions as well, like myeloma, but in rheumatology, these are things we think about. This is classical undergraduate teaching, erythema marginatum, and if you see this with the acute polyarthritis, then you think of rheumatic fever. So this is how, these are the things we think about when a patient with polyarthritis comes to us. So, and then with this background, I'm going to just take you through to the rheumatoid arthritis. So, because if you understand this, you will understand most of the management. So I'm going to stress a little bit on the management here. So rheumatoid arthritis is really the brand new disease, I have to say. It's important to know this fact because a lot of your patients will come and tell you that I have rheumatoid arthritis and I've tried Ayurveda, I've gone to Kerala, I've spent lots and lots of money to try all sorts of natural medicines. What I always tell them is there are some conditions like, say, gout or even psoriatic arthritis, which has been described even in Egyptian mummies. So any condition which is old, we assume that our older health systems can have a remedy. But any condition which is new, for example, the coronavirus, it's a brand new condition. If someone says that, oh, I have some medicines for it, please do not trust it. It will be wrong because there's no research done on it. That's the same with rheumatoid arthritis. The earliest description of rheumatoid arthritis was only in 1800s. And I don't think there's been any research on any sorts of Indian medicines like Ayurveda, Siddha, homeopathy, Unani. Sorry, homeopathy is not Indian, but still the most commonly used in India. They have not done any research on it in the last 200 years. So there cannot be a cure of rheumatoid arthritis in these health systems. But in our specialty, we have really come to near cure. So we will give the patient full remission. This, just to give a flavor, this was the earliest paintings recording of rheumatoid arthritis, which is currently there in the Madrid Museum, which the maid holding the fruit basket having some PIP swelling. In fact, this is the oldest. There's no other documentation prior to that. So what is important to rheumatoid arthritis, you have to pick it up really early. So clinically, based on the pattern and all those, the demographics and the symmetry and everything I mentioned, based on that, you have to pick it up clinically. If you still can't do it, then you try to use the investigations. So CCP antibodies is really revolutionized. So because it can pick up rheumatoid arthritis on early stages. Ultrasound of the small joints of the hands are also useful occasionally. MRI and triple phase bone scan, we don't use it routinely, but just keep it in the mind. It can sometimes really be useful. Say if a chief minister comes to you and asks for to confirm with 100% certainty, then you can use this MRI scan. So this again, I have told you this, but I want to reiterate this, that this pattern recognition rheumatoid arthritis is very important. So someone comes with this PIP joint of the middle finger and the index finger swelling, this has to be rheumatoid arthritis. It cannot be anything else. And if you feel it, you should have a synovial feeling to it, not bony. This is atlantoaxis subluxation, which you have to remember in patients with rheumatoid arthritis, because the reason why I put this here is, so these patients, when they go for any procedures, especially the orthopedic surgeons, when they go for procedures, make sure you inform the anesthetist that these patients are at risk of having atlantoaxis subluxation, cord compression. If not, they will maneuver the neck improperly. So they have to be very gentle to the neck. This is very topical in rheumatoid arthritis, a cardiovascular risk. Again, the reason why I have put this here is most patients with rheumatoid arthritis will come and tell you that I can manage my pain, I'm 70% better. So let me just carry on with the current treatment. But you should not be satisfied with that. You should always advise the patient to get to the extent of near cure or keep the inflammatory burden as low as possible. And that's very important. The reason being, The inflammatory burden is the main reason why these patients are at increased risk of having heart attacks. So if you have rheumatoid arthritis, you are almost at the same risk of having having myocardial infarction as much as people with diabetes. People don't know that. If you have diabetes, everybody knows that you're at risk of having heart attack. But that's the same with rheumatoid arthritis, especially if your inflammation is not controlled. But if you keep the inflammation level to almost to zero, which means you should feel 95% better, then then the risk of heart attack becomes significantly less. And this is an important message to pass it on to the patients. If not, they will not be compliant with the treatment. You'll see that most of the patients with diabetes or thyroid problems, they take the tablets very well, but the rheumatoid arthritis, their aim of treatment is just pain control. And if they can reach to a level of pain being bearable, they're actually not bothered anymore. And that should not be the case. You should also make them live longer. With regards to CCP antibodies, I've told you it's very useful in picking up early rheumatoid arthritis. And in one of the study by this in the Swedish blood bank several years ago, they've said that it can be detected even 10 years before the onset of erosions in rheumatoid arthritis. It has, unfortunately, the same level of sensitivity as rheumatoid factor, but has a very high specificity of 95%, which makes it having a good positive predictive value, which means if someone has CCP antibody positive at a significant titer, you really don't have to think about anything clinically. They have to have rheumatoid arthritis. And it's such a good positive predictive value. But that's not the case with rheumatoid factor. If the rheumatoid factor is significantly high, in fact, it is most likely to be Sjogren's syndrome than actually rheumatoid arthritis. So rheumatoid factors are significantly high with Sjogren's syndrome. And in fact, sometimes I believe that they should be called the Sjogren's factor and not rheumatoid factor. But if the CCP antibody is positive, you can close your eyes and say that this patient has rheumatoid arthritis. Ultrasound is very useful, very underutilized by the non-rheumatologist, but we rheumatologists believe that's very, very useful. So if you are in doubt, you can request the sonographer to do a powered Doppler ultrasound of the hands. So that has to be mentioned, the powered Doppler ultrasound, because that picks up the synovial circulation. So if the circulation is more, there's inflammation. So this is too sensitive. Sometimes you can have inflammation even with osteoarthritis, which also it picks it up, but that's okay. As long as you're aware that this can be too sensitive in picking up inflammation. But this has got a good negative predictive value, which means if the ultrasound is normal, then they do not have inflammation. So in that way, it's very, very useful, especially when some patients, again, high-fly patients, who just come with the joint pains and they want to be certain that they do not have rheumatoid arthritis. The only way you can do that is actually by ultrasound of the small joints of the hands. So going to the management, I think long back, the older physicians and orthopedic surgeons would have read about this pyramid of treatment of rheumatoid arthritis. And now we got an inversion of the pyramid of the treatment. So it used to be the upside down, and now it's that the tip is at the bottom. The reason being, now we have started using the disease-modifying agent and even biologics early on. So the earlier you use, we call it a window period, like the thrombolysis window period. We have a window period for the treatment of rheumatoid arthritis. So the earlier you treat, that means from the onset of the symptoms to within 6 months, if you treat them with a stronger disease-modifying agent or even biologics, then you can guarantee the patient that they will go on a complete remission with a zero problem, okay, after the year. And in fact, some studies in UK have also shown that if you treat them aggressively in the beginning, after 1 year, they can even go drug-free, which means they can go on a drug-free remission for about 3 years in about 1/3 of the patient. And this is nearly a cure. So nowadays, I've started telling the patients that we can cure rheumatoid arthritis, provided we start the treatments, disease-modifying agent early on. So I think we allopathic physicians are very modest and we don't tell the patients that we cure. And this is one of our problems. But actually the studies have shown that we can cure them. And if we don't, the problem is usually due to the patients because they come late. So I always blame it on the patient that you came late and that's why I don't cure. But if not, I could cure this problem. So the expectations now for rheumatoid arthritis are all like very, very high. So it is not just improving the quality of life. We are reducing mortality and we are eliminating, not just preventing, we are eliminating disability. With regards to the tablets, so we don't use NSAIDs anymore at all for rheumatoid arthritis. So mainly because it increases the cardiovascular risk. Even a short period non-steroidal anti-inflammatory drugs can actually put the blood pressure up and make you at higher risk of developing heart attacks. So I don't use NSAIDs at all for rheumatoid arthritis. However, I have not mentioned here, steroids, we do use it for first 3 months only. You can either use oral steroids, intra-articular steroids, or intramuscular steroids, the same as what we use for post-viral arthritis, 120 milligrams triamcinolone on a monthly basis for 3 months. So for first 3 months, because the disease-modifying agents take time to start working, you can use steroids, or not you can, you should use steroids. And on top of that, we use the disease-modifying agent as early as possible on the first visit itself. Do not wait. And we have huge list, but the commonest nowadays, everything has gone out of fashion. Only 3 drugs which we use is sulfasalazine, methotrexate, and leflunomide. And in general, people do talk about combination and all those things, but in worldwide, what is accepted currently is step-up monotherapy, which means you start off with only methotrexate. And especially in Indian patients where compliance is a big problem, monotherapy will give them a better compliance. So start off with a methotrexate and increase the dose. And if they fail to it, or if they're partially effective, then you do the combination. If they fail to it, you replace. But if they're partially effective, then you use the combination with other disease-modifying agent, which is usually sulfasalazine or methotrexate. Methotrexate, the starting dose of methotrexate is 7.5 milligrams. Please remember. Okay, so do not start anybody on 2.5 or 5 milligrams unless they have CKD. Otherwise, the starting dose has to be 7.5, and through the experience and generally worldwide, what we know is that if you, on an average, the patient will need at least 15 milligrams of methotrexate to control the disease activity, unless you're a Japanese population. For some reason, Japanese don't tolerate higher dose of methotrexate. But on average, most Indians need 15 milligrams of methotrexate, and nowadays, most days start them off with 15 milligrams, unless they have a very small build. And folic acid you give 2 days later. So weekly once methotrexate and weekly once folic acid. And that's all that I give. I don't give any tablets, no unnecessary calcium, vitamin D, or daily folic acid. All those things is just going to decrease the compliance. So just give weekly tablets. The subcutaneous route or the intramuscular methotrexate is usually very efficacious, but obviously patients don't like it. So we only use it if at a higher dose of methotrexate, basically beyond 20 milligrams, we believe that they can get a lot of nausea, and the pharmacokinetics such that the absorption is poor, bioavailability is poor beyond 20 milligrams. So if some patients are needing higher dose, then we switch on to subcutaneous or intramuscular route. The blood test monitoring is monthly for the first 3 months and then 3 monthly. And mostly it's only the liver. You don't need to monitor the kidney for methotrexate unless they already have a pre-existing kidney problems. Sulfasalazine, the dosage, please remember that the starting dose is 500 milligrams. It's mostly to prevent or identify the sulfa allergy. And then you have to gradually increase it up to 2 to 3 grams per day. The minimum effective dose of sulfasalazine is 2 grams per day. A lot of the times I've seen patients getting only 500 milligrams twice a day, which is 1 gram per day. And usually they're not effective. I always give an analogy that you don't give 1 milligram of amlodipine. You always give minimum 2.5. So when same the blood pressure, it's the same here. So you don't give a substandard dose, okay, unless there are exceptions, obviously, like very small BMI or kidney patients and stuff. So in general, almost 99.9% of the patients will need minimum 2 grams of sulfasalazine per day to control the disease. With regards to efficacy, methotrexate, sulfasalazine, and leflunomide are all the same. They're all very efficacious. But methotrexate is used as a first line for all of them because of the fact that it's a weekly tablet, so the compliance is better. But if there's a woman of childbearing age group, methotrexate is contraindicated due to teratogenicity, and we give sulfasalazine. The sulfasalazine, the monitoring has changed long back, but people don't know this, is the monitoring is decreased to just 3 monthly for first 2 years, and then you don't need to monitor at all. That's another advantage of sulfasalazine for Indian population. Whereas you don't need blood test monitoring, which decreases the cost significantly after 2 years. Leflunomide is equally efficacious. The only disadvantage is slightly more costly, and the liver function tests are slightly more with leflunomide compared to methotrexate and sulfasalazine. And there is also another small caveat to it. It also increases the blood pressure. So we don't recommend it in people with high blood pressure. And the standard dose is 10 to 20 milligrams per day, depending on how big or small they look. Quickly on the biologics, we have so many available now. We are spoiled with the options. The commonly used one are etanercept, which is used weekly 50 milligrams, adalimumab, 40 milligrams subcutaneous protein fortnightly. Golimumab is very expensive, so we don't use it, but it's available, but it's monthly. So very poorly compliant patients, we can use monthly. What is interesting with this biologic is this is for the first time, the biologics have shown to reverse the erosions. So this window period I was talking about, that 6 months or 1 year if you start the DMARD. So biologics, if you start a little bit later also, you can still go back to complete remission. And that is one advantage of biologics. It can actually reverse the erosions, which the older DMARDs only can prevent further erosions. So these biologics have grown a lot. So it used to be initially used only in established RA, but now we are increasingly using it in early RA. In fact, if I get rheumatoid arthritis, I want to use it as a first line. But standard practice is methotrexate followed by biologics. There are, again, the technology is advanced significantly. There is a terminology, there's an international standardized nomenclature for it. So you have to understand that if it is Ximab, it's a chimeric. If it's a Mumab, it's fully human. If it is Zumab, it is humanized. So it's all very standardized, even if the name sounds like a jargon, but it's all very easy to understand if you understand the nomenclature. So I'll just skip this. And then the risk of the biologics for anti-TNF especially, the only major risk in India is reactivation of TB. So we never do anti-TNF without screening for TB, which includes TB Gold and chest X-ray. And only if they're negative, we give it. If they're positive, then we treat that first for the latent TB, and after a month or two, we can start anti-TNF injections. Other side effects are just purely academic. The risk of cancer originally was mentioned, but nowadays we know that it does not have an increased risk of any cancers. There are several other biologics which are available and used in rheumatoid arthritis. Rituximab is really wonderful. The efficacy is as good as anti-TNF, but it has a slower onset of action. But otherwise, the compliance is so good, which means if you treat them at 0 and 2 weeks, and that will work for about a year, so patients doesn't need any treatment, and that's quite attractive. But slower onset of action, what makes it being less attractive. Abatacept is also available. Tocilizumab is also very interesting. Worldwide, this is shown to be superior to any other biologics for rheumatoid arthritis, but in India, the response is slightly less, and we feel it's probably just similar to other biologics. They're all different, mostly from the cost point of view. The side effects point of view are not a worry whatsoever. The infection risks are the least with rituximab and abatacept, but in general, the infection risk is the same compared to the age and sex matched population for rheumatoid arthritis. And this is really upcoming. We have a lot of small molecules. Unfortunately, this is also of similar price to the biologics, but it's a tablet, but as efficacious as the biologics. So this TNF works intracellularly through NF-kappa B, and then causes inflammation, which is blocked. So if it's blocked at the cytokine level, it's anti-TNF. But we now know there are other intracellular signaling molecules such as MAP kinases and Janus kinases. So if you block this intracellular signaling molecule, and that also creates a similar anti-inflammatory effect. So tofacitinib was the first to arrive to the market, and now we have baricitinib as well, and both are available in India. Tofacitinib is JAK1 and 3 inhibitor, and baricitinib is JAK1 and 2 inhibitor. They are, as I said, very efficacious. They have slightly different side effect profile. There's a risk of herpes zoster with these small molecules and thromboembolism. So because of this, we don't use it as a first line, but still efficacious in people who are resistant to most treatment. And that's the end of my talk. Thank you. So, any questions, Vishal? Yeah.
Thank you very much, sir. I must say, very insightful and very knowledgeable for all the entire audience. And I'm sure that everyone in the audience must have enjoyed the session, must have learned from the session. I'm sure that everybody has get to know about more details into rheumatology. And the good thing about the session is that, sir, we have not only gone through the diagnosis part from the initial treatment, but went through all the treatment options available, from
I think
aggressive
that's
to
important. That's
normal.
why.
Yeah, that's important as well. Yeah. So, no, so as you said, treat early and go aggressive from the beginning only. So that is going to be the major conclusion for the day. There are a few questions, sir, which has been asked from the audience. I would like to take one by one.
Okay.
The first question is that how to diagnose seronegative rheumatoid arthritis?
So rheumatoid arthritis, as I've said, is a clinical diagnosis. So if they have symmetrical polyarthritis affecting the MCPs, PIPs, which is inflammatory with significant early morning stiffness, that's rheumatoid arthritis. Then the blood test comes after that. So if you do a blood test, neither rheumatoid factor or CCP antibody, positive or negative, it just gives us this terminology, seropositive rheumatoid arthritis or seronegative rheumatoid arthritis. It really doesn't change the management initially, but it gives a prognostic value. So if somebody is seropositive rheumatoid arthritis, that means they will behave slightly more aggressively, which means they will end up being in a wheelchair in say 3-4 years. Okay, but if someone has seronegative rheumatoid arthritis, it looks just like rheumatoid arthritis, but just that blood is negative. That means they're going to end up in a wheelchair maybe after 15-20 years. So for prognosis, it's useful. For initial management, it's not useful.
Okay. Thank you, sir. Moving on to the next question. Which is the choice of DMARD when it comes to the overall treatment of rheumatoid arthritis, or it's a combination?
Methotrexate. No, always methotrexate. I've told you the worldwide, the most commonly practiced one is monotherapy, not a combination. So, as I said, in India, specifically due to compliance, it's better you start monotherapy. If not, they're going to end up stop taking the tablets. I always feel that if you give 10 tablets, they're not going to come back to you in a month's time. Okay, yeah.
Right.
So you slowly build up later. So methotrexate is the first line DMARD. Starting dose is 7.5, and you have to build it up to minimum 15 milligrams per week.
Right. Yeah, as you have mentioned in the presentation also, it should be always 7.5 milligram to start with.
Yes, except if CKD.
Except with the CKD cases, yeah. Right, sir. So one more question. Dr. Ramesh is asking actually, how is anti-CCP better than the rheumatoid factor?
Yeah, I've told you because of the positive predictive value. It's very specific. So sensitivity and specificity of rheumatoid factor is about 70% each. And with CCP antibodies, sensitivity is 70%, but the specificity is 95%. So other exceptions just being a heavy smoker, they can have a slightly high CCP titer. So, so that is the difference. So it's got a very good positive predictive value. So someone has CCP antibody titer high, and if they're not a smoker, usually we have women where we're suspecting rheumatoid arthritis. Then you can, even if whoever denies on earth, you can tell them clearly that it's rheumatoid arthritis. Even if they don't have pain, you can tell them that you're going to get rheumatoid arthritis later. Right. Okay, so in that way, it's useful.
Last question, sir, for the session. Is there any role of checking RF factor regularly? Right.
No. Yeah, that's a very good question. Please do not repeat rheumatoid factor. Okay, it's only useful in the beginning to tell the prognosis to the patient. Okay, so only in the initial stages, that is also to tell the prognosis. So, so you don't have to repeat it. So the variation, the rheumatoid factor normally varies quite a lot. It's like taking immunoglobulins, so it varies quite a lot. So it doesn't indicate the activity of the disease.
Thank you, sir. And there is one more question. Shall I take it, sir?
Yeah, go on.
Yeah, just asking on the lighter side, I think, when to stop the rheumatoid arthritis therapy, like when to stop the DMARDs and all.
Yeah, I've told you that. It all depends on how soon you start. So it's not that we cannot stop. We normally tell everybody don't stop it, but that's because patients present to us late. Okay, right. So if the patients present early, within 3 months of the onset of the pain, okay, so that is why there are, not in India, but all over the world, lots of expert rheumatology centers have started doing early RA clinic. So where the awareness is quite good, people do come to them very early. So in early RA clinic, especially, we start them on DMARDs very early, within 3 months, and then quickly switch on to biologics if they don't respond. Then yes, after a year, you can stop. 1/3 of them can stop. Okay. No treatment is 100%. Like even COVID, Trump gets all the treatment, but you can't guarantee he's going to get better. Okay. Right. So we hope 95% chance he gets better. So same thing. There's a 33% chance that the patient can be cured if they start the DMARDs and biologics early, which is within 3 months of onset.
Right. So with this, I think we have done with all the questions, sir.
Yes.
And I must say once again, thanks to you. Thank you very much for giving us your precious time today.
Thank you all. Thanks for
looking after
listening.
your patients and OPD for the day. And I really thanks to everyone in the audience as well for giving your presence in the session today. And I'm sure that you have enjoyed the session. You have learned a lot from this session. So with this, I announce to close the program, sir. And with your permission, yeah, to
Thanks for
goodbye to
listening. And thanks,
everyone.
Vishal, and thanks to Zydus. Bye. Yeah.
Yeah. Thank you, sir. Thank you very much. Bye, everyone. Good night.